2 minutes each, please. Thank you.
Thank you, Madam Chair. My name is Bill Grimm. I'm with the National Center for Youth Law, and I'm also a member of the QIP expert panel that Pete spoke about. And I've been working on this issue since the fall of 2012. I want to begin by thanking both you, Senator Mitchell, and Senator Monning for recognizing that the approach to ensuring better health and safety for our kids in foster care is a multifaceted one. Your legislation addresses the different facets of this problem, both in terms of reforms in the court, training for the people that are involved in overseeing children, and Senator Bell's bills around public health nurses and enhancing their work in this area, as well as focusing upon the high user group homes that I think Senator Stone spoke about. I just want to leave you with one additional piece of information that was not available when the oversight hearing was held back on February 24th, which again I think calls out and is further evidence of the crisis that we are facing and that we can no longer wait any longer to address this problem. And that's the Office of the Inspector General's report released less than 2 weeks ago about the use of antipsychotic medications amongst both Medi-Cal and children in foster care. And in that report, the OIG found that in 41% of the cases, it was the wrong psychotropic medication. The antipsychotics was the wrong treatment. In 53% of the cases, they documented that children were on these medications were not being properly monitored. In greater than 2/3 of the cases, there was at least one area of quality of concern about the child's care. And this applies not only to our children in foster care, but to our Medi-Cal children, children on Medi-Cal who are not in foster care, who are receiving antipsychotic medications. And the last thing that I'll leave you with in terms of that report is that California, which is one of 5 states that the OIG looked at, was the least cooperative in providing information to the federal auditors. We provided information in less than 2/3 of the cases in which the OIG requested information. We have got to do better on this issue, and we have got to move on this issue this session. And again, I'm so glad, Senator Mitchell and Senator Monning, for your support in this area. Thank you.
Thank you. Next witness, please.
Madam Chair, members, Ed Howard with the Children's Advocacy Institute at the University of San Diego School of Law. There's an additional facet to this which is insusceptible to talking about merely prescribing practices and generally applicable laws, as excellent as your bill is. And that is that the caseloads of the last line of defense for these children when it comes to checking to whether or not psychotropic medications have been properly prescribed, the last line of defense in any law that you will enact in this legislature is the child's lawyer. And so long as the caseloads of children's lawyers are 500 children per lawyer in Ventura County, over 350 on average in Los Angeles County, 400, I believe, in Riverside County, so long as the caseloads are that high, this problem cannot get solved. Children will continue to be prescribed inappropriate psychotropic medications because the person who is supposed to be their champion simply can't be their champion and their voice, and that's their attorney. Thank you.
I think I'm carrying that bill too, Mr. Howard. So.
You are carrying that bill.
Okay, golly.
I know that you're modest that way. I did want to point that out.
Next witness, please.
Thank you, Madam Chair. Frank Mecca, Executive Director of CWDA, and I too want to thank the Chair and Senator Monning and Senator Stone for your interest in the issue. We're the proud co-sponsors with the National Center for Youth Law of your bill, SB 238. As the agency with the care, custody, and control of kids in the foster care system, we're responsible for overseeing the well-being of foster kids. It's our belief that to some significant degree, to the extent there's an overuse problem with psychotropic medications, we need to, as a matter of public policy, arm the practitioners, social workers, judges, attorneys, CASAs, with better information about what kids have been prescribed, what they're taking, how those drugs might interact with other medications they're taking, whether or not there's atypically high or potentially dangerous dosages or potential combinations. What other mental health therapies are the kids getting? This isn't just about whether or not kids are getting too many drugs. It's really about are kids getting the full package of specialty mental health services that they need. Your bill, SB 238, that we're co-sponsoring, is one of a number of ways different ways to come at this problem. And for us, we're building on the really excellent work of the two departments to allow us to match data between what the Medi-Cal claim system knows people are paying for, and then what we know about the foster kid. And so if we have better information about what kids are taking, what they're not taking, how that might affect them, and how that interacts with the rest of their treatment plan, and we can monitor their well-being and advise juvenile court judges, who are ultimately the ones responsible for approving a psychotropic medication, we think we can do a much better job overseeing the use. And so that's a brief little commercial on SB 238. And again, just want to thank both the departments and the legislature for taking on what is an extremely significant and serious problem.
Carol Schroeder with the California Alliance of Child and Family Services. Chairman, you raised the question of what are the providers doing, and I wish I could speak for all of the providers, but I can't. But let me speak for our members. Our experience, our goal is this: how do we assure that the right child gets the right treatment, and the right dosage at the right time for the right period of time, and that what that child is experiencing or what the child is getting actually has a beneficial effect? And that's not just with regard to psychotropic medication, but with any treatment, any kind of mental health treatment or any other thing. To the extent that the bills have been, the bills that have been introduced and are working their way through the legislature now help make it possible for that to happen. We are absolutely in support of that. And for those that are somehow or another obstruct the ability to do that, we want to continue to work with the sponsors and the authors. I want to thank Mr. Grimm and the National Center for Youth Law for reaching out and working with us on this, because we agree it's an extremely difficult situation. It's a very concerning problem. We look forward to continue to work with them to address this in a way that works for kids and families.
Thank you very much. Next witness, please.
Thank you. Christopher Castrillo on behalf of the California Academy of Child and Adolescent Psychiatry. I want to speak specifically to the issue of the treatment authorization request policy of DHCS. The agenda notes that DHCS has indicated that these issues have been addressed and that it's not aware of any systemic issues with the TAR process. We just want to note that we have still been experiencing a number of problems with delays, deferrals, denials for kids who need and benefit from this medication. As important as we recognize the issue of trying to restrict the inappropriate use of antipsychotics and psychotropic medication within the foster care system, this is a policy that does span both foster care and Medi-Cal. I do also feel like it's important to note that Mr. Hendricks, Mr. Wofford, and Mr. Gasper have been very responsive to this point in terms of addressing our issues on a case-by-case basis, and we do certainly appreciate that. However, that has not yet resulted in solving the problem on the front end. And so we just want to make it known that we are still looking forward to trying to iron out the issues with the implementation of this TAR process. And I'd like to thank you for your time. Thank you.
Thank you very much. Next witness, please.
Good afternoon. Thank you, Senator Mitchell, Senator Monning, and Senator Stone for your interest. My name is Anna Johnson with the National Center for Youth Law. I'm a policy analyst. I've been on the Quality Improvement Project since its start in 2012. I'm probably the only member that's not an agency staff on all three of the work groups. So I've sort of seen it from the beginning to now. And I've also studied the policies on the national level and on state levels that have helped to give kids safer care, more appropriate care that follow medical guidelines and standards. These guidelines and standards about psychotropic medications have existed for over a decade by organizations like the American Diabetes Association and the American Academy of Child and Adolescent Psychiatrists. Guidelines don't change the reality for children. There are many reasons why children are over-medicated in foster care. What we have from our Quality Improvement Project are documents created by experts that have been brought together through a valuable learning process. But without changes to the law or to the legal landscape, those children will still experience a lack of appropriate and safe care that follows those medical guidelines. I really appreciate all of the bills right now that are looking to address and to put some actual regulation into this practice. Because without that, what we see is exactly what Bill Grimm has mentioned from the OIG report, that monitoring doesn't happen, that without training, the courts and the attorneys don't know how to challenge prescribers that may not be doing what's best by children. And so what we really need to do is take a look at how do we do more than an ACIN with documents attached for children. How do we actually make sure their life is safer and that they are getting those services before drugs are tried? Part of in the Quality Improvement Project, one thing I've advocated for, and I haven't seen happen yet, that I'd like to see happen, is in our data agreement, we have some look at psychosocials. But I think more can be done to flesh out exactly those services that youth really benefit from, that are trauma-informed, and to take a look at who's really getting those, where are they getting those, and what placements are they getting those. And I really appreciate, Senator Monty, your mention of the influence of prescribers who have been given incentives, and I think that's another place to look. So thank you, everyone. We will charge forward, and I appreciate, Senators, your support.
Thank you very much for sharing your perspective with us. With that, we will move on to Department of Social Services. This is deja vu all over again, Director. Child Welfare Services Continuum of Care Reform.
We're still here.
It's a good thing I can laugh at myself.
Right. As we move into this, I just want to sort of, in a sense, segue from the conversation we were just having, because just to emphasize something, as Mr. Mecca said, and I think this is supportive of what Ms. Palmer was just saying, ultimately, information in the hands of the practicing social worker who is responsible for the case becomes essential. And I cannot thank too highly and commend too highly Pete Chervenka for the leadership he has given to really sort of working through the incredible intricacies of developing the data sharing agreement, the global data sharing agreement with the Department of Healthcare Services. It changes our landscape. And I know many staff worked with him on it, but it would not have happened had he not kept pushing it. So I just wanted to thank him. As we go into the CCR conversation, perhaps one other segue is this. At the oversight hearing that this subcommittee did with Senate Human Services on the psychotropics experience, one of the presenters was describing, and this was Ken Barrick of Seneca, was describing the fact that in a residential program they were operating, they started with a population of youth, almost all of whom were on psychotropic medication, many of them antipsychotics, and how within a period of time they were able to sort of work supportively with them to end that usage in most or all of the cases and make it possible for the youth to transition into family-based settings. And that's basically what the CCR is about. Not to sort of single out Seneca as being, you know, the only great example. But I particularly want to say it because I don't want CCR to be understood as condemnation of the group home industry, because we have some very, very fine residential care providers. What we want to do, in a sense, is focus in on using them for what that great strength is, which is that intensive treatment that Ken was epitomizing when he talked to you, and not using congregate care as a sort of a long-term placement, frequently for older youth, where that's just sort of where they end up. Because the danger to that is a self-reinforcing set of dynamics that whether the use of medication follows the acute need of the child from the beginning, or whether the acute need of the child is produced by the institutionalizing dynamics of long-term placement, who knows? I mean, and I don't think we can unbundle that in any time frame that's going to make much sense to anybody. But so I just wanted to start by saying this is not a condemnation of the group home congregate care industry. It's a let's use it for what it should be used for strategy. In the past, when the congregate care conversation has come up in the state, in legislative forums or study groups, it has focused just on group care. And I think predictably has sort of petered out over time because at the end of the day, the question was, as opposed to what? And because those questions weren't being answered, the efforts didn't have a place to get to. What the CCR, the Continuum of Care Reform, tries to address is an interdependent set of developments that make it possible for youth who are entering care, coming into care, to be assessed appropriately, early, by a child family team, be provided with the set of services they need then, not wait for them to fail up after a series of lower level placements, but rather say if they need intensive treatment in a structured setting that would be congregate care, that they enter that with a plan that is specific to the child, that has an exit strategy attached to it, an exit plan, and that the expectation be, by and large, that be 6 months or less. Case-by-case extensions if justified, but extensions supported and signed off on at a very high level in the local child welfare agency, so that it's not the default. And then having children and youth, as their needs are being met, being moved to lower levels of care with the services that they need to maintain them in those lower levels, following them to the lower levels. That presupposes the existence of a strong supply of resource family homes, a strong supply of quality resource family homes. And we have many very wonderful resource family homes, and we have some that may not have the wherewithal to handle kids. And we need to have a process that's honest about it and works from it. As we do that, we have to have a method, as we anticipate this, the child or youth moving to lower levels of care, there has to be a mechanism to support and, i.e. finance the services that they need. We think it has to be a flexible approach because needs will change. The youth who seems stabilized at age 11, then enters puberty, and things will change. And having that ability with doing the reassessments in a timely way so that, yes, the needs increased, and we can respond to the caregiver's request for additional services and supports has to be an essential part of it. What this, of course, implies is that congregate care will ultimately be used only for short-term treatment. And so we sort of, in a sense, rebranding it from group homes to short-term treatment centers. We expand on the work being done through, it's going to get confusing, we have a QIP and we have a QPI, the Quality Parenting Initiative, which is now in, I think, 17 counties, that is really looking at what are the qualities that we're seeking in caregivers, how do we engage them, how do we keep them, how do we involve them, how do we make them partners, and how do we establish mutual expectations so that in the language of the QPI agreement that a parent enters into with the agency, the parent has the foster parent has the support they need from us, and the foster parent commits to things like, if the child is going to a medical appointment, the parent will take the child and comfort them. And that care and comfort concept is what we need to build out. This obviously isn't an overnight transition, and it'll have to be phased, and that's what we're proposing. The role of the foster family agencies may, in many cases, at least for those that have treatment capacity, be enhanced so that counties have the option of having the treatment foster family agencies continue to provide services, not just in FFA certified homes, but also in county recruited licensed homes or in relative kin care homes, so that the service doesn't stop further up the line and then the child is left in need and ultimately moving back up. Intrinsic to this is the integration of mental health and child welfare that's been discussed before. It builds on the KDA concepts and more. And ultimately what we are envisioning is the STRTCs and the treatment foster family agencies will have to be able to essentially be certified by mental health as mental health providers so as to accomplish that. We have to do rate setting for the FFAs, the treatment FFAs, that works and is flexible as the needs of a child change. That process actually starts tomorrow when we bring together our partners, providers, stakeholders, and advocates to look at how to structure that. And then it really depends on outcome measurement and evaluation, with a particular focus on which providers are getting the outcomes that are being sought, and also including the youth voice in what is their sense of satisfaction from the care and services they've received. The stakeholder group with whom we consulted to develop these recommendations strongly included the youth presence, and they were particularly concerned that their voice be there. Several of the things that are implicit in this have already occurred. The approved relative caregiver rate to equalize payment levels for caregivers with non-federally eligible children, as you heard earlier, is in place. The increasing the age requirements for staff in congregate care, and that was done as part of last year's budget. And the resource family approval process, which is approved legislatively to go statewide, is now in early implementation in 5 counties. And so that's part of where we go with this. The governor's budget has 2 specific components to begin the CCR implementation, totaling just short of $10 million total funds. The first is where we have to begin all of this, which is in that expansion of the availability of quality foster homes. And the way I frame it is it's foster home retention, recruitment, and support. We have to be able to retain the homes we've got. We have to be able to give them the supports and quality they need. Recruitment is important, and we have to do that, and then support. The $3.8 million, which is devoted to this activity, is intended as 6-month implementation, so it's half-year funding to start in January. Between now and then, we'll be sort of working with counties and stakeholders to look at the sorts of activities and approaches that we should be investing in at the beginning. Things like family finding right at the intake process into the child welfare system with those counties that haven't yet done that. Many have, some have not been able to. Retention activities with current foster parents, using new methods to locate and identify potential new foster parents. What we don't want to do is put more flyers in more church basements all over again. We've been there and done that. And then supporting the Quality Parenting Initiative and resource families. The second component in the proposal is the increasing of the foster family agency social worker rates. That's the component of the rate that is paid to the social workers by 15% full year, a budget year. This frankly recognizes that they are having a difficult time retaining staff at this point. It would probably be about a year before a rate setting process would lead to relief through the rate setting process, and we want to be sure that the partners we want to have involved with us are still with us when we are there going to those stages. And so we don't look at this as solving all of the problems that we know they have, but these are the sort of initial investments of the administration to get CCR going. As you know, the overall continuum of care reform is being carried as a policy bill, AB 403. But these 2 items immediately we're proposing in the budget process.